Uh, so I work as cataract, cornea, and refractive consultant at Retina Foundation, Ahmedabad. So I'm going to present a case which I've done few years back about managing a traumatic subluxated cataract, glaucoma, and mydriasis. I have no financial interest. So this was a 32-year-old patient had history of trauma on road traffic accident. When he presented, he had this corneal edema. On staining, he had epithelial defect also, and his pressure was very high. So basically, for acute management, we gave him topical steroids, anti-glaucoma drops, but there was a corneal opacity after healing, and which did not reduce after 2 to 3 months. So we did PTK for him. After PTK, 3 months, we took him for the case for the surgical intervention. So as you can see that this the pupil was there was no dilating drops used. The pupil was big. There was a huge mydriasis, and the epithelium was still irregular, which we had to remove it for better visualization as well as a better healing later on. Now you can see that there is a subluxation of the cataract from around 2 o'clock to 5 o'clock. So we go ahead with the case. As this was a glaucoma case and the patient was not compliant with the medicines as well as his glaucoma was not controlled. So we decided to go ahead with a trabeculectomy. With one tip I want to give for the trabeculectomy is whenever we are putting this MMC soaked balls, you count it while putting it and count back again while removing it, because if by mistake if this MMC soaked ball remains, it can cause scleral necrosis and ischemia. So once this was done, after a thorough wash and this partial thickness scleral flap, we move ahead for the cataract surgery. I generally prefer a temporal incision. Here it is even better because superiorly my trabeculectomy is there. So we start with this have side ports and main port. Once that was done, uh, sorry, I'll just forward it a bit. Once that was done, the rexis was started. Now it is very important to have a good rexis, especially in a subluxated case, because there is no way you can put the lens in sulcus. So if your rexis goes out, you have to just do some kind of SFIOL or SFIOL. I think that's the only choice we will have it. This particular patient had a little bit of difficulty in rexis, but we could manage it. Again, I prefer doing hydrodelineation in any traumatic cases, any subluxated cases where there is zonular weakness, so that there, while doing a case, there is no further strain on the zonules. Now, this was a very soft cataract in my hand. Such cases I do generally by irrigation and aspiration. So we finished off the lens aspiration with irrigation and aspiration, and because of the subluxation, I put the CTR ring. Now, one tip I want to give while putting the CTR ring is when we come to the end, always do the two instruments so that you ensure that the CTR goes inside the bag. Otherwise, it can sometimes go into the sulcus. Then the three-piece lens is my choice for such cases was put, and the haptic was oriented in the subluxated area. After this case, now the biggest thing was what to do for the pupil. At that point in time, I thought, although I would do something different now, but at that point in time, I thought that I want to give this patient a nice round pupil. So I decided to go ahead with the post ring pupilloplasty. Now, any case of pupilloplasty, what you need to do first is try and kind of release the synechiae. That will help to form the angles little better. Also, you get some kind of iris tissue, especially in this patient, the iris was just not visible. So I will get some kind of an iris tissue for me to actually hold and put my needles through. So after pulling the iris 360-degree, we have some kind of now iris rim to play with. In this post-ring pupilloplasty, what we use is we use the one double-armed 10-0 Prolene suture. Uh, so when the 10-0 double arm Prolene sutures, yes, it comes generally with a straight needle, or at least what we have in our hospital are with the straight needle. So I curve it with the needle holder, and from this nasal side port, the side port opposite to me, I introduce the needle and take the bites. Ideally you should take small bites. This iris was, because of I think the increased intraocular pressure during the acute stage, there was a lot of iris atrophy. Iris was very, very fragile, and iris, what every bite there was one hole which was forming in the iris. Ultimately I took few bites and I take out the needle, retrieve this needle with the help of 26 gauge needle from the inferior side port. Now you can notice that iris was coming out continuously because it was so floppy that any movement was causing iris to come uh, out of the incision. So to continue with this pupilloplasty, we have to introduce the same needle which we have retrieved out of the side port through the same side port again and complete this particular quadrant. Now, when we complete this particular quadrant again, the needle comes out through the main port. Now, this side of the pupilloplasty or the bites were complete with one side of the needle, which goes from this side port, then comes it out from the inferior side port, and then comes it out from the main port. So with the help of 26 gauge needle, we got it out from the second main port. Now the second arm of the tenoproline goes from the same side port from where we initially started. That is the side port which is opposite to you, where you are sitting. That is the nasal side port in this case. So you do the similar procedure again. You introduce the needle and you take the bites in all the quadrants, doing the same thing, taking the needle out again and introducing it through the same side port. We complete the 360-degree pupilloplasty and we get the needle out through the main port. Now we have both the needles out through the main port. Here again you can see the iris is coming up. I don't know whether if I had used the iris maintainer, maybe it would have been slightly better, although it is little difficult to take iris bites with the continuous flow, I guess. So I did it under the visco and we gently put the iris back. Now we have two threads which are out of this main wound and we have to pull it just to make the pupil smaller in size. Now you have to remember that you need a size which is good enough for the patient to not have photophobia or glare. At the same time, because this was a glaucoma patient and he had a trauma, he may have anything with related to retina later on. We have to have enough size where the retina examination can happen, because these pupils generally do not dilate, they are sutured pupils. So once you are happy with the size of the pupil, you give the second and third knot and you cut the thread with the micro scissors. You can notice that because of the atrophic iris, there are so many atrophic patches and there are 3 or 4 holes which had happened in the iris, which I think I could not avoid doing it. So once we cut this, our pupilloplasty was over. In such cases, sometimes I like to give the suture over the main tunnel and then we shifted back to the trabeculectomy side. This is, I like the end block dissection for my trabeculectomies with the knife. And we removed a small around 1.5 to 2 millimeter end block dissection, removal of the trabecular area. At this point in time, after doing the PBI, what I noticed, and I didn't want one more thing in this case, was vitreous started prolapsing from that. Maybe because I cut the iris slightly more posteriorly, and it gave a chance. It gave a kind of formed a channel towards the vitreous cavity. So we did the localized vitrectomy for this particular case, and after that, after localized vitrectomy, the vitreous did not come back again, and we closed the scleral flap with one suture and with 10-0 nylon. And I generally close my conjunctiva also with 10-0 nylon. So this was the case where we did cataract with CTR, we did pupilloplasty, post-string pupilloplasty, and we did the trabeculectomy. So there were too many things were already there, and we added a bit of anterior vitrectomy in this particular case. Now this case later on follow-up looked pretty good, even those holes were like kind of had healed pretty well. Patient's photophobia decreased quite a lot and patient's vision improved. If you see, even his epithelium has healed so much better than before, and his best corrected visual acuity with little bit of refractive error was 6.9. His IOP is also well maintained. You can see a nicely formed bleb in this case. Thank you so much.